Okay, everybody, this is chapter one. We're going to go through the PowerPoint. Um, I'm using Plural Publishing PowerPoints because they're very thorough. I'll add some information to them, and then we'll talk about it when we meet on Tuesday. So, in the introduction, I talk about the consequences of hearing loss and how it impacts all aspects of a person's life, social, vocational, basically every aspect of their life. It primarily reduces the person's ability to converse efficiently, and so therefore often you'll see issues with intimacy and friendship and social situations. So again, as we talked about, oral rehabilitation seeks to restore or establish, in the case of children, which is habilitation, a patient's ability to communicate. And then our job as audiologists and SLPs to alleviate the difficulties related to hearing loss, but also to minimize the consequences of said hearing loss. And whether it's a social consequence, it's a vocational, it's educational, it doesn't matter. So the World Health Organization, most of you have probably heard of the WHO. They have a classification for functioning, disability, and health. That classification primarily looks at the consequences of the health-related condition within the context of that individual's environment and their day-to-day needs. So when we talk about patients with hearing loss, of course, the focus is on how it affects their everyday life and how this hearing-related disability is alleviated. And then there you can see the definition of a hearing-related disability. It's defined as a loss of function imposed by hearing loss and denotes a multidimensional phenomenon, which may include pain, discomfort, physical dysfunction, emotional distress, and the ability to carry out their day-to-day activities. Here's some terminology that you can take a look at. At the core of the visual is activity, and so it's all about how the hearing loss negatively impacts the individual's ability to perform activities. And again, it can range from social, vocational, educational. When we talk about oral rehabilitation with kids, it's educational, but as they get older, then you have that you have that vocational component. So once students hit about, 15, 16, oftentimes we have to take that into account. At the bottom of that visual, you can see, where it says environmental factors, personal factors. Some of those personal factors can be as simple as transportation to appointments. If they don't have transportation, they don't get effective hearing rehabilitation, and so there's a whole host of things. And again, we'll go into each one of those whenever we talk about adults versus children and so forth. So take a look at the take a look at the terminology there. So here's an example of how everything's kind of interwoven and interlinked. So for this patient, you have a professional musician, okay? And so obviously played in loud concert halls, has damage to hearing, and now no longer can do some of the things that are required of his or her position. So one of the things it notes is because of the hearing loss, they're no longer able to regulate voice pitch or quality. So that limits a vocational component. Can't sing the harmony with the band. Obviously, that reduces that participation there. Has to wear earplugs during concert to ward off any further hearing loss. And then avoids publicity, like interviews and so forth, because of a fear of misunderstanding. Okay. And every individual we see has this same the same concerns pretty much. So some of the services that are involved in AR plans initially have to diagnose and quantify the type, degree, and amount of hearing loss. And I'm assuming all of you had some intro to audiology course. We'll talk about that. And we'll go over looking at audiograms, being able to tell if it's a conductive, mixed, sensory neural loss, how much loss, and so forth. Almost every plan includes the provision of listening devices, usually in the form of hearing aids. There's informational counseling. We talk about communication strategy, training, helping people understand what strategies to use for enhancing communication. Some people really need this assertiveness training. Some people don't. Some people do. Psychosocial support and counseling. Auditory and speech reading training. So enhancing a person's ability to speech read or lip read, take advantage of those visual cues. Intervention related to speech, language, and academic achievement. That's often a component for younger patients. Hearing protection, if they're in consistent noise, and then tinnitus management, which is often aided by using hearing aids and different programs within hearing aids that can help them deal with tinnitus. Where does it occur? It can occur anywhere from university, speech and hearing clinic. You don't see it as much in audiology private practice, mostly because you can't bill for these services or rehab services. But so primarily university, speech and hearing clinics have them, sometimes within the schools. But there you can see the list of all the potential locations where AR can occur. So who provides oral rehab? Oftentimes with adults. The first person of contact is the audiologist, because there's concerns about hearing, a hearing test, hearing aids fit often. And then, so we're kind of the primary person there often. Not all the time, but most of the time. With children, oftentimes the SLP is more involved, especially in school environments. And then, but it's important that the audiologist and the SLP possess this knowledge of auditory system function and disorders, and what... And that's one thing you'll learn in this class is, okay, you have Johnny Smith and he's 6 years old, and we're going to look at audiograms and we're going to say, okay, based on this audiogram without hearing aids, how much of the speech signal is Johnny missing? And then we'll look at some audiograms with testing with the hearing aids in place, and then look at, well, how much is it improved? Okay. And even if you're interested in speech language pathology, that's something you need to be able to understand, look at, and explain to parents, because you will often be in IEP team meetings if you're in the schools and or even if you're in a rehab center. And so you have to have a good understanding of what the audiogram shows us with hearing aids, without hearing aids, and then be able to explain it to parents oftentimes. So here is a visual. It's kind of what we do as audiologists. We're looking at a bunch of different things when we're determining the amount of hearing loss. Number one, How severe is it? Is it mild? Are they missing 20% of the speech signal at average conversational level? Are they missing 80% of the speech signal at at average conversational level? What have you? When did the loss begin? For adults, sometimes it could be very gradual, sometimes it's sudden. What's the cause of the hearing loss? And then how quickly has the hearing loss progressed? Okay. One thing within oral rehab, we talk about hearing age, and hearing age is essentially the amount of time the person has had access to auditory information. So I always use the example of a 40-year-old patient who was born with severe to profound hearing loss, has not worn hearing aids during that time, has communicated via sign language, and then decides, that he or she wants a cochlear implant. Well, they are implanted, they activate the implant. Their hearing age, once the implant is activated, is 0, right? So they're starting fresh. So that's what I mean by the concept of hearing age, and you're going to hear about that a good bit. So again, we're looking at the audiogram, and I'll have to email you and see how comfortable we are with interpreting audiograms. I have a program that can make audiograms, and I'm going to make some, and I'll put them in a PowerPoint, and I'll do a voiceover so we'll go through it, make sure you understand how to interpret audiograms, and that sort of thing. So we'll be sure. But again, in case you haven't done that yet, audiograms, of course, measure hearing sensitivity at various frequencies. And it's plotted on a visual like you see on the slide. So one of the descriptors that we use to talk about how much hearing loss somebody has is what we call the pure tone average. The pure tone average is usually an average of the thresholds, or the X's and O's on the audiogram, at 500, 1000, and 2000 hertz for the most part. Those are the 3 frequencies that we use. So if you look under normal, pure tone average is 25 dBHL or better for adults. For children, it's 15 dBHL or better. So the important point there is, for children, we have more rigid and strict requirements for normal hearing than we do for adults, because children are developing language. They need more auditory access than adults. They don't have language experience that adults have, so they need better audibility. And then you can see mild hearing loss is a pure tone average between 26 or 16 for kids and 40 dBHL. Okay, so this is showing you how the pure tone average can be used to specify a degree of hearing loss for an individual. Okay, down at the bottom, it says those with profound hearing loss are called deaf when we're talking about specifically the degree of hearing loss. When we're talking about the culture, right? So beyond hearing sensitivity, we use the capital D in deaf culture. Okay, and we'll talk about that more throughout this semester. So here's some definitions for the onset of hearing loss. Prelingual, which is acquired before the acquisition of spoken language. Perilingual, during the acquisition of spoken language. And there's no set kind of agreed upon ages for this. And then there's postlingual, which is acquired after spoken language has already been acquired. Congenital, which means present at birth. And then acquired, which means it occurred after birth sometime. Okay, and it could be in childhood, early, at any time, basically. Now, 3 different types of hearing loss. If you haven't had much on this, we'll go over it. But we have conductive, sensory neural, and mixed. Conductive is usually due to some obstruction